Hey folks, welcome to our webinar today. We're not starting yet, so don't worry. For those of you that are going to be joining us, we're going to talk a little bit and then we'll bring Hudson on here shortly to talk about what's new in COVID-19. So I'm joined by Blake Hotchkiss. Say hi, Blake.
Hey guys.
And I'm joined by Hudson Garrett, that unfortunately today, Dr. Garrett cannot join us on camera because someone evidently ran into a pole near his house and his electricity went off. But nonetheless, say hi, Hudson.
Hello.
He is an expert in infection prevention in a lot of the issues with the CDC, with the FDA, with EPA. He holds a lot of degrees and has lots of certifications. Let's just say that he is an expert in his field and we're very lucky to have him. Hudson, let's take it away.
Perfect. Well, good afternoon to everybody on the phone. You should see my slides coming up here in just a second. This is an update to what we did before, and I think there's a lot of interesting information out there specifically about what's going to happen in the future, and that's really the focus of today's program. Since we are offering continuing education, as Judy mentioned, I do want to share my disclosures. And really, when we look at the objectives for today, specifically, we want to think about where are we going in the future? What are we going to be doing? And I think one of the biggest issues right now is if we miss this opportunity for preparedness, we're really, really crazy. We need to make sure that we stop and take that information and do it correctly and really sort of map out what our future is. We also recognize that there's going to be a couple things that are going to change with regulatory bodies, accreditation, clinical guidance. I see several of you on the line that I recognize names of, and many are in the world of infection prevention, and the guidance changes, it seems like, every single hour. And lastly, I want to make sure every single one of us is safe in the work that we deliver. That's a huge, huge risk there. This is the disclaimer that I always share. Again, we want to defer you to your local public health authorities, and you can always visit the CDC as well. So this is a picture of me last week, unfortunately. You know, this has become a big part of my life of dealing with these patients, and I'll tell you, it's brought an eye-opening experience about what's important in life. I was telling Judy and Blake, I had a patient here lately that unfortunately was abandoned by her family after being diagnosed with coronavirus and was a hospice patient. And this is probably one of the more tragic things that I've personally seen. And it reminds us of how important it is for us to remind ourselves about really what we're trying to do. The first thing we're trying to do is keep ourselves and our patients safe. We also need to provide accurate information. And without going into any details, I think we can all think about some of the stuff that's been on the news media from politicians, from government leaders, whoever, you name it. I happen to live here in Georgia, and as you've probably watched the national news, there's a lot of controversy about reopening the state right now with the sort of pandemic numbers that we're seeing here. And so part of it is sort of taking the hysteria out of the equation. As I mentioned before, one of the other things that we want to be really cognizant about is how do we prepare ourselves for the future? What are we going to take away from this? What are we going to do with PPE? How are we going to adjust our staffing models? Are we going to do things to prepare our families for this type of situation? And then lastly, what are really the rational decisions that we need to make? So, I love this picture because, and maybe it's not in all parts of the U.S., but I know that I struggle to find toilet paper because people are hoarding it. And it's, it's sort of a funny, depiction of what's taking place out there, but there's a lot of information that is just simply not correct. So I go back to this picture of what my Publix used to look like, and certainly think about how do we get back to a sort of normalcy in the future. I also want to stop and simply say thank you. Many of you are either directly or indirectly caring for these patients. And I'll tell you, I haven't slept right since this happened. I wake up early in the morning, which is not what I normally do. And it has certainly taken a toll on every single person that I've talked to that's interacted with this. So whether you're a clinical educator, if you work in industry, if you work at the bedside, it really doesn't matter. You're all playing an integral role in this, especially around these patients requiring vascular access. And this is such a huge opportunity to showcase the excellent talent in the vascular access community. So what's going on with the federal response? Well, there's been a lot of stuff that's taken place. If you've probably watched the news here lately, there's some exciting developments around the vaccine trials. Those are going far quicker than we expected. There's going to be more widespread availability of the antibody testing, and we'll talk a little bit more about that here in a second. And something that I really appreciated is this public-private partnership. If you think about ventilators as a perfect example of something that is truly life-saving, right? And we thought we were going to need a ton of ventilators, and so the Defense Production Act has kicked in, and hopefully we never go through this another time in our lifetimes, but it is an opportunity to say there are people stepping up to the plate to do the right thing and to really help. And I think one of the biggest obstacles that we all face is, all the procedures that you're doing in vascular access require PPE, and in many cases, sterile PPE. And so we really need to think forward and say, how do we work with our supplier partners to ensure that we have the right adequate supply lines? So what's going to happen in the future? Well, there's a couple things that I would say that are going to happen. One is we're going to move away from just the testing to say, are you positive or are you negative? Do you have that active infection? We'll see more antibody testing to, again, look at sort of exposure. If you've looked here lately with the study that just came out of New York, where about 25% of the population they believe has antibodies, this certainly sort of raises the red flag to say there were a lot more exposures than we even anticipated, and most of those people did not even require healthcare delivery services. So that's a good thing. Florida has done a phenomenal job of contact tracing to really sort of look at what were the pathways of these individuals that were infected. What were they actually doing? Who did they touch? Who did they come in contact with? And how do we backtrack that? One of the sort of unfortunate realities that I've seen is how fragile our long-term care system is from this. And I've worked with long-term care for many years as a consultant, but taking residents out of these facilities with coronavirus has been a horrifying experience over the last 3 months. And those that I work with are having similar experiences where these patients are sometimes cohorted in a room, 3 to a room. They have very little vascular access services available to them. The nursing staff is overworked, certainly, and there's sort of a stress in the system of even having access to PPE in the first place. So we need to think sort of collaboratively about our continuum of care. Now, certainly, if we could get to a vaccine, we're going to be in a much better position, but we're not there yet, and we don't, know the exact time frame. So in the meantime, that therapeutic option of where do we sort of bring the medications together? What are those best practices? And, there's a lot of debate about, do we need a randomized controlled trial? There are lots of studies that are ongoing that many of your patients may be enrolled in that will help us identify what those best practices are. But we also want to stay away from things that are sort of, just completely out there in the media with no evidence base behind them. So the Johns Hopkins map, as I've mentioned before, is updated continuously. I updated this one this morning about 9 o'clock this morning. So you can see the total number of cases on the left. And I've actually drilled down, and this is a new map that's available if you've not seen this, that actually looks at the United States and hotspots. So you can actually go to the website that's listed on the bottom of the slides, and it'll allow you to do this. But this is interesting to zoom down into your own community level. So why is this important? Well, if you're a hospital and you have a catchment size of, let's just call it 8 counties, you might want to know what the transmission is from a community standpoint. There's also a new map available that looks at the total number of cases reported by jurisdiction. And the key at the bottom got a little bit cut off there, but it'll actually tell you that the darker states are those that have the highest level of incidence. And so again, if you're a healthcare provider and you're looking at what are the best practices we should take as far as screening our patients, should we cohort, what engineering controls should we take? These are sort of the data points that I would recommend looking at in collaboration with your infection preventionist to make those decisions. And it, again, gives us real-time access. This is stuff that's updated on a daily basis. One other thing that I thought I would point out that's quite interesting, and I was telling Judy about this last week, is this new sort of social impact events. And really what CDC is looking at is where was their transmission at sort of, let's just call it an unauthorized social event or mass gathering. And I'll tell you, this is a very interesting thing to look at. So this one was for 72. There were 72 total events just in the past 24 hours that were reported to state health authorities and in turn reported to CDC. So you can see the location of these. So some of these may be in your community, but this is a really different way for us to look at the data. So for example, if you're called down to the emergency department and you've had multiple patients that all require, let's just call it IV access, and they need some assistance, and they all have similar symptoms, and then they all have been exposed at the same place, you can start to see that cluster form. So it's just an interesting thing. When we look at the clinical presentation of these patients, we're seeing sort of a sway in this. Historically, we've talked about that traditional dry cough. They were febrile, usually a temperature above 100, and certainly shortness of breath. And if you've seen some of the pictures floating around of these patients that have been intubated, the sludge that's coming out of their lungs is pretty incredible, to say the least. That being said, that sort of clinical presentation can vary. And specifically, I want to address these asymptomatic carriers and supershedders as well as pediatrics. So some of you on the line may work in a dedicated pediatric facility. Others may have pediatrics floating in and out. But we're seeing a lot more testing that's being started in the pediatric world, and many of these patients are presenting asymptomatic. And so while we understand that the general population, there's been studies out there between 25 and 50% of people may be asymptomatic, we need to continue our screening efforts a lot longer than just some of these sort of shelter in places that are being lifted. And so as a healthcare provider, our sort of mode of operation is going to be very different than what the politicians are recommending. The average incubation time can go out to 14 days, as we talked about before. But when we think about these super shedders, most of these folks can be asymptomatic, but they are carrying high viral loads. And so what does this mean in clinical practice? Well, these are folks walking around that we may be interacting with that actually may screen negative when we do our symptom screening, ask them the questions, those types of things, and they have no idea that they're ill. And so they can actually be problematic for us in the healthcare setting. The case fatality information has also changed. And so the most recent data that I saw as of last night shows about 0.5%. So we're still higher than seasonal influenza, but we're actually lower than what we thought we were. And again, the risk goes up exponentially by those patients that have significant comorbidities that are chronic in nature. Last night alone, I know New York State released some additional data, and they essentially looked specifically at New York City. So they sort of zoomed in and looked at those patients in the medical records and found that about 90% of those patients that required hospitalization and ventilation and those types of things all had at least one, if not more than one, chronic comorbidity. So it's something that we should be aware of as we're screening patients, but also thinking about ourselves and protecting ourselves as well as our families. I unfortunately have a friend that's a nurse in New York City that's there on a deployment, and she hasn't seen her family. She hasn't, she's only been able to use technology to talk to them, and it's a terrible situation for folks. We recognize also that many of these patients are going to require some type of ventilatory support. However, one of the interesting things, which I think is good, is that we're really backing off on this aggressive intubation principle because we recognize that a lot of these patients, if they get on a vent, don't do well. And so they're certainly going to require a lot of vascular access support as well as medication support. And that's another thing, is that the supply chain of some of these sedatives and medications that we're using to keep these patients calm is running low. And so again, our medical system has to sort of adapt and say, what other therapeutic options might we need to keep these patients safe, or can we extubate them, those types of things. The routes of transmission are evolving again continuously. We've seen now the recommendation of wearing some type of facial covering. I thought about putting some interesting pictures in here that I had, but I decided against it. But just yesterday, I was at a healthcare facility where a nurse was wearing full PPE, including a face shield, a gown, booties, head covering, you name it, she had it on. And I proceeded to watch her walk outside of the facility, get into her personal vehicle. I think she made a phone call, sit in the personal vehicle, and then get back out of the personal vehicle and walk back into the healthcare facility. And, so some of the practices, of just giving somebody PPE without training or competency are not really effective. We also recognize that the recommendation of a cloth mask is not at all protective towards you. It's simply protective toward you transmitting to others. So these cloth masks are not FDA regulated. They're not studied. They're not approved for that purpose. and even basic surgical masks have a shelf life, especially if they become moist. And so it's really important to make sure that we're appropriately using our PPE. There are probably going to be more recommendations coming out from CDC in the next few days about even not using respirators unless it's an aerosol-producing procedure. And that sort of information is out there to a degree, but it's going to become more widespread over the next few days based on sort of the understanding of the shedding of the virus, how it can sustain itself on a surface and in the air, and best practices associated with that. So what do we do to limit that risk of transmission? Well, certainly community transmission is huge for us. Again, we need to think about our patients that may be asymptomatic. And so there are different things depending upon the practice environment that you work in. So for example, in the critical care setting, we're using a lot of pulse oximetry to determine where is this patient sort of in the journey. Are they at big risk? How are they sort of, dealing with their oxygen saturation from a perspective of, are we at the time where we need to consider ventilation that's invasive? Are they doing okay? And also capnography is another one that we're adding to the mix, but pulse oximetry continues to be really the gold standard here. The other thing we want to think about too is the pediatric market. And again, we have not had that widespread testing available for everybody. And if you look at sort of the priority, we're testing healthcare providers first if we can, symptomatic people, and then we could look at asymptomatic folks as far as carriage. But as far as isolation principles, we're worried about you as a healthcare provider and those that are actually symptomatic, most importantly. Just yesterday, LabCorp released a take-home test, if you will, where you can actually order the test and do it in the convenience of your house. And you may say, well, why in the world is that a big deal? I can get testing anywhere. Well, every time we do a test, that requires PPE. And so I was even talking with Blake earlier about a role he was playing to help his hospital. And, when you put on all that PPE, you're taking that away from the frontline healthcare providers. So anything that we can do from a diagnostic standpoint to identify these at-risk patients that doesn't require us to be put at risk and doesn't hurt the supply chain further is something that we should think about. Judy, do you want to go ahead and do the first poll question? I'm very interested in the results for this.
Yeah. And we're looking at 37% have seen no patients, and another 37% were in the 0 to 10 range and kind of fallen off from there. 17% were 11 to 30, and too many to count, 9%.
So, I would venture to guess that those of you that answered in the first 37% of no patient contact probably actually have had patient contact, but most likely did not realize it. And so I think that's something that we really got to think about as far as those asymptomatic folks as well. From the time that we spoke last, when we did the last AVA webinar, there has been a tremendous amount of community spread that has been documented. Just the data from New York City alone, if you think about the potential of 25% of a large U.S. city, having been exposed to the point where they show antibodies, this is certainly concerning as far as sort of the general incidence of the illness. But it tells us actually a very positive story that most of those people did not require any type of healthcare intervention. Because when we compare that number to those that were hospitalized, and those, unfortunately, that had negative outcomes as far as not making it from this virus, we're in a very good position as far as understanding it a little bit better. We do, however, want to think about our very vulnerable populations, those that we can actually intervene on. And I cannot stress enough how important it is for those of you in the hospital to work with our long-term care partners. These are folks that have limited resources. They don't have the nursing teams that you do in a hospital setting. And pretty much everybody there is a victim of polypharmacy and multiple comorbidities. And so we need to try to do everything in our power to sustain those residents, hopefully in their own environment, and keep them out of hospitals if we can. But if we do have to care for them in the long-term care setting, they're going to need vascular access support. The average nursing home that I've dealt with in the critical care environment, as far as doing transports, most of these folks have no idea how to start IVs. They don't start IVs. It's sort of a hodgepodge from outsourced services to we just don't deal with this and we call 911. And that's certainly a shame for these patients that could be maintained well in their own practice environment if possible. And again, we want to look at sort of understanding these children and pregnant women a little bit further. So what are sort of those core practices that we can emphasize? And I'm going to talk about some changes that have been happening here, but certainly our biggest thing is to minimize exposure. So I want to say a little bit about that. Depending upon where you live, your environment as far as the community may be rapidly changing. So for example, I live here in Atlanta. And as of today, there are certain things that can open legally. On Monday, in-person restaurants can open with certain restrictions as well. As somebody who is educated about this virus, do I have a desire to probably go sit in a packed restaurant? Absolutely not. Would I consider sitting in a restaurant where there was adequate social distancing and I 100% knew that the staff had been screened and they were taking adequate precautions? Yes, I would consider it. I don't think I would rush to do it. And so it's really a matter of sort of personal preference in sort of balancing the risk versus the benefit equation. And certainly, we also want to be sensitive to many of us on the phone. Many of our colleagues may be living paycheck to paycheck. And so there's sort of this dynamic that we have to think about, especially for those of you that are supervisors, to really support each other, to make sure that we're taking care of our teams. But, that really starts with minimization of exposure. The next thing we'll talk about is some of the different recommendations that have changed with standard precautions and how do we sort of do more with less, and maybe we need to back off some things. And I'll give a few examples here in a second. One of the sort of difficult things that's come from this, unlike anything that I've seen before, is sort of the lack of presence of visitors in our healthcare facilities. And, I'm a huge advocate, and I don't know if Beth Gore's on this call, but if she was, I'm sure she would agree. We all need an advocate as a patient. And I can't think of a better one than somebody like her. But when we're in a hospital setting especially, we need somebody there to advocate for our own safety and to make sure that we're receiving proper care. And they don't have to be a clinician, but they need to have our best interest in sort of mind and not be afraid to speak up. And right now, we don't have a lot of that. And so we're seeing especially nursing personnel and even physicians and other healthcare providers that are literally filling that role. So they're not only the clinical care provider, and we all try to maintain somewhat of a distance so that we can be professional and not become so emotionally engaged. And that can be very hard right now because we have patients that literally have no one else at their bedside during their last few hours. And so it's really taught us a lot about the value of the services that we provide. Engineering controls can get as creative as you want. My own supermarket within 4 days put up plexiglass between me and the teller or the cashier. And it is interesting to see how quickly you can do things when you really want to do that. And part of that is starting with training and education and competency and then looking at the environment. So as far as screening, this again is changing based on the symptomology of these patients. And so what I would recommend is sort of to develop a basic screening questionnaire. Many of you are probably already being screened, and then be prepared to add to that as needed. That being said, when we get a few months away from now and we get into flu season, this is going to become more problematic because of the similar symptomology. And so it's not something that's going to be instantaneously ruled in or ruled out based on the screening questionnaire. And we might have to look at real point of care testing to determine, is this person been exposed? Do they have immunity? And immunity is sort of a difficult term to discuss right now because we don't know that if you've developed antibodies, if you have immunity and for how long. When we look at some of the data that's coming out of other countries like South Korea, even some out of China, there is a reinfection rate. And we need to better understand that so that we can clear somebody to ensure that we can return them to work properly. Blake, I think it's time for our next poll question, so I'll let you put that up.
Well, thanks, Hudson. Well, let's go to number 2. Launching the poll. What is your comfort level with your facility's current supply levels of PPE? 16% were not sure, 17% said very comfortable, and 15% said worried to death about PPE.
Blake, I don't know about you, but those bottom two scare me. And I very much sympathize with those of you that are worried to death about PPE. Judy knows this, but I invested in my own PPE stash several months ago when I was unfortunately worried about something like this happened. And it's, let's just say it's alarming to see how few PPE devices we have and things that we have as healthcare providers that we really need. That being said, I think one of the great opportunities we have is to figure out, are there other ways to skin the cat that don't require us to rely on disposables only? So we'll talk about that here in just a second, but let's keep on moving. So when we've got patients that are coming in, again, we can do the screening. We can also look at adding things like the antibody testing. So, for example, if you've watched any of the news media outlets, anyone who's coming into the White House right now is being screened. And there very well may become a time where hospitals are doing that, at least for a period of time. I'm not saying that's going to become mandatory or anything like that, but it certainly is realistic to think about our sort of point of care testing. You know, we're able to screen for influenza, we can screen for hepatitis. There's a lot of different variables that we have. And the laboratory technologies are becoming so sophisticated and easy that we could probably do this on a widespread basis, you know, within the next 12 months. And so, you know, especially patients that are coming out of hospitals, going back to other facilities like long-term care, they're pretty much getting screened. And that's normally a requirement so that the receiving facility has some idea if this patient is COVID positive or not. The other thing to think about is sort of those transitions of care. So if we're going into place a PICC line as an example to provide for fluid replacement or antibiotics or whatever it may be, we want to have a better understanding of that big picture of that patient. What's their risk exposure been? How can you maintain sterile barrier precautions, you know, while wearing all this other PPE? These are all things that we have to think about. And look beyond just the traditional respiratory etiquette stuff that we talk about frequently. And again, as we get into the fall and winter months, this is going to become more problematic if we see a resurgence because we're going to have these different symptoms sort of popping out at the same time. So let's talk now about what's changing in the world of PPE. And I've got some new graphics that CDC released that hopefully will be very helpful for you. I'm also going to provide a link that I'll have Judy send out following today's presentation that's got some additional video resources in case you're looking for some good evidence-based information. So we're certainly not moving away from basic standard barrier precautions. So we're going to have our exam gloves. One of the top questions that came up on the last webinar, and I've had several emails about it in the last few weeks, is it recommended that we wear double gloves? And the answer is no. You know, we did that for Ebola because it was a bloodborne pathogen transmission route and the copious amounts of fluids and secretions that were present, but that's not currently a recommendation. Another question is, should I wear a gown or should I wear a coverall? And again, either one of those is acceptable. I personally like to wear a coverall. For me, it's a lot more comfortable. If I'm going to be going in and out of different environments, it's a lot easier to do that. But again, then you have that potential risk of cross-transmission. So it would really only be a best practice to wear a coverall if you're actually working in a COVID unit, for example, or if you might have prolonged contact with the patient and then you're going to take it off. That would certainly be acceptable as well. But that's really more of a personal preference. But either the gown or the disposable coverall would be fine. Obviously, the biggest debate is with this NIOSH-approved respirator. Having just recently had a dental emergency, I realized very quickly how uneasy the dental practices are to deal with dental emergencies, and rightfully so, because they don't have N95s. They don't have respirators. Many of them barely have any regular surgical or procedural masks left. And when I met with my dentist, I had a crown that fell off, and I had to go in for them to put it back on. And they asked me the questions, and I could see the eyes get bigger and bigger and bigger when they said, "Have you been exposed to a corona patient?" And I said, "Yes." "Have you been exposed to one that's been known and tested positive?" "Yes." "How many have you been exposed to?" And I just saw the eyes get bigger and bigger. And so I jokingly provided them both a respirator mask that I had in the car for them to wear. But, you know, it really brings to home how important it is to think about not just us that are working in sort of those traditional acute care environments, but the other healthcare delivery services that have essentially completely stopped functioning. Dental practices, primary care practices, even some of our urgent cares have closed or done reduced procedures. And so the ASCs is another example. The fourth one on the list is eye protection. This is something that I'm very passionate about because I think we don't do a great job of this in general in healthcare. But eye protection is not your prescription eyeglasses. It's not something that's just going to protect the front of your eyes. It also needs to protect the side. And so OSHA regulates this, and they're not joking about this, and rightfully so. So we want to ensure that we have something that's going to completely cover our mucous membranes, our eyes, our nose, our mouth. For me, I personally prefer a face shield, similar to the one that I had in the picture. It's a lot more comfortable. It's easily cleaned. I can reuse it multiple times. But again, it provides something that's going to protect that facial barrier, if you will. And again, it's all about personal preference for you. So when we think about eye protection, how are we going to do this in the world of vascular access? Well, safety glasses would probably be certainly fine. There are also different masks that have fluid shields built into them as well. But you also want to consider, is this something that's going to be aerosol producing? So if there's anything going, and I give you a perfect example, what about humidified oxygen? Or if the patient is on a ventilator, or if the patient is receiving a nebulizer treatment. These are all things that are going to increase the potential risk for aerosols to actually gather into the atmosphere. And while they don't survive very long at all in the air, they will fall because they're droplets. It is something that we want to think about. And we also want to ensure that we're properly disinfecting and removing our PPE. In a conversation I had on Monday, I believe, with a colleague at CDC, we were talking about some just general best practices. And one of the things she wanted me to mention on today's webinar was that when they've done sort of root cause investigations of healthcare providers across the world that have contracted this virus, that were all wearing PPE, the number one reason that they contracted the virus was not the use of the PPE, it was the improper use of the PPE. And so specifically taking this stuff off is of huge risk to us as healthcare providers, especially the respirator mask and how we handle it. And so there is a new poster that's available. I will send the link out to that, and Judy can share that with the group as well. So this is an example of something that we should not be using. Somebody sent this to me, and I thought it was quite funny because there are so many different sort of, let's just call it adaptations and creative ideas out there. The number of people when I've been driving to work that I have seen wearing masks in their own cars alone is astounding to me. The number of people that I've seen wearing gloves to drive their own personal vehicles alone is astounding to me. Now, if you want to put on a pair of gloves at the gas pump, go for it. I personally wash my hands or use an alcohol-based hand sanitizer. But if you're going to wear personal protective equipment, let's make sure we wear it correctly. And so I think us as healthcare providers have an obligation to educate the public if we're seeing these bad practices. Because not only are we putting those individuals at risk, but we potentially are putting ourselves at risk. And so, you know, there was a video that was actually on the local news here, and they were showing somebody eating at a Whole Foods inside the store. And of course, they weren't really supposed to be doing that. And they actually had a mask on, and they were literally lifting the mask on and off, back and forth to sort of, you know, eat their meal. And the news reporter said, you know, walked up to the person and said, "Is this something that you're aware of? Do you know you're supposed to not be doing that?" And the guy said, "Well, you know, it doesn't matter. I'm going to do what I want to do, but I'm still wearing a mask," not realizing that those sort of intermittent breaks are actually what's causing some of this community transmission with the vapor. So when we transition to respiratory protection, what do we do if we don't have a respirator? Well, you know, if you look at CDC guidance, if you are not doing an aerosol producing procedure, then you don't necessarily need an N95 respirator. And I want to make a personal comment here. This is not an evidence-based comment, but a personal comment. If you have access to an N95, go for it, wear it. But let's not deplete the supply chain for people that are at very low risk of transmission. Those that are actually caring for confirmed COVID patients or persons under investigation that are symptomatic, that's really where our first priority for this level of PPE needs to be, and certainly for those that are in aerosol-generating procedures. I've got several friends that are in the anesthesia world, and they had to fight to get N95s in the perioperative environment. And certainly that's an area where there's risk during intubation and things like that. The other option to look at is things like PAPRs. And I would highly suggest that vascular access teams really invest in this technology. There are ways that we would have to adapt this to maintain our sterile barrier precautions, but if you think about sort of the ability to continuously deliver care and also maintain our own provider safety, a PAPR is an excellent opportunity to do that. If you're not familiar with what a PAPR is, it's a self-contained sort of breathing apparatus that creates sort of a negative pressure environment. The advantage of it is that you can wear it continuously until the battery runs out. And so some of these batteries go up to 10 hours, I think are the longest ones that I've seen so far. But it's a lot more comfortable. It doesn't rely upon you reprocessing things and stuff like that. You can clean the PAPR hood, or some of them are actually disposable as well. But, you know, hospitals have, I think, especially, you know, stepped up to the plate and tried to be creative and figure out how can we reprocess things. But our goal, of course, is to not have to reprocess items that were designed as single use. That's really our goal. That's not where we are right now, but it's certainly something that we need to move towards. And then how do we do this within the confines of the OSHA regulations around testing. So Blake, let's put up that next question because I think it'll have a little bit of relevance.
All right, coming at you, launching the poll. Have you been fit tested for the use of a N95 respirator?
I'm very interested to see what the answers are for this one.
Me too. Let's see here. All right, let's close it up. 90% were yes, they've been fit tested. 9% said no, and I'm guessing somewhere in the less than 1% says I don't remember.
Perfect. So I'm very excited to see that with one caveat. Each of us may, our bodies may change, our facial hair patterns may change if we're men, and so it is important to make sure that while you may have been fit tested once, that you are fit tested if anything significantly changes, especially if you've got facial hair, you're not going to achieve a good test. You're not going to pass well with that. And the other thing to think about too is, what about if I have a different type of respirator that I'm being offered at work? Unfortunately, I've seen many stories, as many of us have, where nurses have either been fired or suspended for bringing their own PPE in. And I completely understand both sides of the equation. I understand the clinician's perspective of saying, I need to do something to protect myself. And I also understand the employer's sort of responsibility, if you will, to say, wait a minute, we're liable for this. And if this piece of equipment is not properly tested by us, then it could be a liability from a workers' comp standpoint and stuff like that. So there's sort of pros and cons on both sides. The solution has to be somewhere in the middle. How do we make sure that we can provide for our healthcare providers under the most dire circumstances? And then what are sort of the stepping stones in place, those sort of performance management systems that will allow us never to get in this position again? And again, we've got a long ways to go from that perspective. The other thing with face mask is that there are lots and lots and lots of counterfeit ones out there. Just yesterday, FDA put out a press release that actually has pictures of how to spot counterfeit masks, both N95 as well as surgical masks. That is available on the FDA website. It's also hyperlinked on the CDC website as well. These are medical devices, and so they do serve a medical purpose, but they're only as good as they are manufactured. They're only as good as they're tested, and certainly only as good as they're worn with the limitations that we have. So if I'm sweating through my mask and it's a surgical mask, it's no good anymore. That membrane is now broken. And if it's one that was never engineered for purposes of medical sort of respiratory transmission prevention, then we're in a bad position. And so it's important to work with your infection preventionist and your supply chain folks to make sure that we have that. With aerosol generating procedures, if you're going into a room to insert a line, do a dressing change, anything related to that, and there's aerosols in that room, you immediately qualify to use some type of respirator mask. Whether that's a PAPR, it could be an elastic, half-face mask. Those are some of the solutions that we'll talk about here in a second. Or if there's going to be any type of risk of that patient coughing. Source control is really, really important here. And if you're not familiar with that term, essentially what we're trying to do is say, yes, we're going to give PPE to you as the healthcare expert, but we also want to put a mask on that patient. And you'll find here when we go through the return to work criteria, if you have a mask on yourself and a mask on the patient, even if your mask is not a respirator, your chance goes way, way down of transmission. And it certainly is going to affect your ability to work if you are not wearing PPE, but it also will positively impact your ability to stay at work if you are wearing PPE, even if it's just a surgical mask. Those of you that are using sort of the mask covers to protect your mask, there's really no specific recommendation against that, but we certainly want to make sure that we're maintaining that and washing that hopefully daily. And then when we remove our mask, we want to make sure that we're not contaminating our hands when we're doing so and practicing hand hygiene right after that. So as I mentioned, CDC and NIOSH specifically regulates respiratory protection, have released this new graphic, and there's lots of different sort of adaptations. So I want to sort of start outside of a hospital for just a second and think about our public safety members. Every fire department has self-contained breathing apparatuses, SCBAs. Those can be adapted to be used in place of a respirator. So when you think about it, if I'm a firefighter and I've got to walk up to a patient that is potentially corona, there's a couple things I can do. I can not send the whole crew in, so I can send one person up to check on the patient in respiratory protection. I can make sure that only one person's riding in the back of the ambulance, so we have minimal exposure. And I can do all of that with my SCBA, which they have ready access to, and they can replenish those with no issues. Now, if we go into the healthcare setting, what most people are issued is those traditional N95 respirator mask. But there are also other things like the half face piece respirator, which is one that I really recommend. I used it with a lot of success. A PAPR is also acceptable as well. So why do I share this with you? Because there are different ways to accomplish the goal. Depending upon what you can get your hands on, it may not be advantageous for you as a vascular access professional to only have an N95. You may actually want to put something in your budget to maybe get a couple PAPRs for the team. Or you may want to actually get everybody their own face piece or face mask respirator. That's another option. There's I think it's actually the last infectious disease hospital currently operating in the U.S. They don't really rely on N95. They give every one of their employees when they're hired a half face piece respirator, and they give them the filters to change it, and they maintain it, they disinfect it, and that's actually what they wear. And so there's a lot more availability of the filters than there is of the disposable N95 type mask. And so really consider what is best for your facility, and then make sure that you try it with the type of PPE that you'll be using. So for example, if you're going to use that half face piece respirator and a face shield, make sure the face shield still fits over it, and most of them it will. We can also do things with our own procedures, like covering the patient's face, making sure they have a mask on. We can use goggles to protect ourselves. And certainly, if there's something that's truly elective and is not medically necessary, then we don't have to do it right away. That is changing. If you looked at the new CMS guidelines, they are really pushing more to restart elective surgical procedures. Outpatient visits will probably start to pick up. And so what does this mean? Well, we're going to have another drain on the PPE. We're going to have people that are going to be screened positive that maybe aren't, and we'll miss people that should be screened positive that we did not. So a large part of this goes back to hand hygiene and keeping the environment as clean as possible. The great news is that if you have pretty much any disinfectant that's healthcare grade, it's going to readily inactivate this virus on the surfaces. So your ultrasound machine, if you've got some type of telemetry equipment, if you're using EKG for placement technology, if you've got chest x-rays, all of that stuff, we can easily disinfect with a regular EPA registered disinfectant. But keep in mind, you're never going to see COVID or Ebola or MERS or SARS or anything like that typically on the label, but there is guidance out there from the EPA which regulates these products that says which ones are effective, and there is a list available. I always go back to Smokey about, only you can prevent COVID, and it really goes back to washing our hands. We have got to focus on the basic core elements of infection prevention. If we have learned nothing, there's really two things that come to mind. One is we need to hardwire our basic infection control interventions like hand hygiene, proper use of PPE, and number two is we need to forecast better what will we actually need to deliver care in a very, very difficult time. One hospital here in Georgia that's been terribly affected by this went through 6 months. They went through their entire 6-month stockpile of PPE in less than 7 days. And so there is a new burn rate calculator available from the CDC that you can actually put all this information in and actually get that. But again, alcohol-based hand sanitizers are very helpful, but guess what? It's really hard to find them right now to the point where people are actually making their own. The World Health Organization actually has a document out there that will tell you how to literally make your own hand sanitizer if needed. But soap and water is absolutely acceptable. And for me, I actually prefer it if I have access to it. It just depends on if there's a sink around. And certainly one of the biggest risks that we have is, again, the hoarding of supplies and equipment. And so it's amazing to see how many people right now are sanitizing their hands. And hopefully that number, that sort of compliance rate of some of these facilities, I haven't seen anybody not wash their hands, much higher than I would normally see in these healthcare facilities. But we want to make sure we don't lose that momentum as we move forward and sort of emerge from this. And it goes back to that old adage of it's not just about now, it's not just about COVID or Ebola or anything like that. We should be always doing this. And so these sort of global events, especially when it gets from an outbreak to a pandemic, it really is a reminder for us of how easily transmissible some of this stuff is, and quite frankly, how easily stopped it can be with some of these basic interventions, which we all have access to. So if we think about ourselves as healthcare providers, certainly there are different things that we can do to affect the curve. One that we rely on so heavily is the use of PPE, but you'll notice that's at the very, very bottom. Things like engineering controls where we can cohort patients. We can put up some type of barrier between patients. Many hospitals have actually gone to a tent technology where before the patient ever enters the hospital, ever comes in the emergency department, they're screened outside. Here in Georgia, we have a makeshift hospital and a convention center. I know New York City obviously has done that. Our colleagues in California, some places have done that as well. And so across the country, we're figuring out what is really necessary. But we also want to make sure that we as vascular access experts are directly integrated clinically into these operations. So yes, those types of facilities are typically for your more stable patients, but we want to ensure that there's a seat at the table for vascular access to ensure that our needs and sort of desires are represented to care for those patients. What are the things that we need to think about? Can we deliver vascular access in those non-traditional hospital environments? CMS also opened the opportunity for ambulatory surgery centers to care for patients if they had that capability, and they were going to waive the restrictions around that. Well, what would that mean? Who will staff it? How will we provide for care for those patients? These are all things that we have to think about. Really exciting development is around diagnostic testing and where do we go now. When we first talked about this at our last webinar, there was really sort of a direct focus on testing for positive or negative. And again, we've moved past that to, yes, that's important, especially if someone's symptomatic. Yes, it's important to determine, who is traditionally sick, but they don't know it as far as those sort of asymptomatic shedders. But we're really moving towards this antibody testing, the therapeutic options, and specifically, what do we do to return somebody to work? And this is really, really important to make sure that those that have been exposed and recovered are safe when they come back to work and don't reinfect others. And certainly we don't really understand the reinfection rate yet. The data is pretty flimsy at best, and certainly we can't necessarily rely on some of the data sources. And so further investigation is noted here. But when we do have healthcare workers that are coming back to work, it's important that we have good stringent criteria that make that person safe, our patients be safe, as well as our coworkers. Because what we don't want to do is return somebody to work that might actually infect others. And this has happened to, I've seen this happen with people I've worked with, as well as those that work in the healthcare community, where an employee became very ill, was out for a period of time, and immediately came back to work. And while I think we all admire that tenacity of getting back to the bedside, we also want to ensure that we're doing it safely. So there is a prioritization that was just released about sort of where should we start with this testing. But you'll see that we've got our hospitalized patients, especially those that are symptomatic, and our healthcare workers with symptoms. Again, I absolutely believe in my heart that we will be doing antibody testing on all of us, especially as healthcare providers, just to determine sort of what that exposure is and then better understand the immunity profile of this. But then we want to think about those vulnerable populations, like those in long-term care, people that are symptomatic, that are elderly, that have underlying medical conditions, and certainly our first responders. Most states especially are treating the first responders just like healthcare workers. And on a personal note, it's been, let's just say, eye-opening to see a lot of businesses that are closed and many times hurting really step up to the plate to try to do what's right for healthcare. Some of the amazing things that you see on Facebook and YouTube and other places really remind us of the sheer appreciation that we need to have for the work and the privilege that we have. And so, hopefully everybody, remembers that on the days that are very, very difficult. And then lastly is sort of looking at that community spread. How do we actually test individuals around us? And if you're in a hospital setting especially, this is going to be really great data for you to have to understand sort of what is that continuous community transmission that's out there. One thing that I think is fascinating, and this was just released on Tuesday, is there's a new tool on CDC where you can actually look at future occupancy, specifically for your intensive care type environments, where you can actually input data, look at your beds, look at your history, and look at potential pandemic modeling, and actually determine what your utilization might be. Well, why is this important? Because earlier I said there's the PPE burn rate calculator available from the CDC. So if I know that if I have another incidence like what we're having right now, and I know my staffing model is going to be different, right? My PPE is going to be extraordinary as far as the utilization. I can more directly forecast what is it that I truly need to care for my patients. Does it make sense, for example, and I've seen this at a hospital here locally where every single employee in the entire building, all of them, all 5,000 employees that work there on the campus wear an N95 respirator mask. You could be a clerk that's not in a clinical area. You could be an environmental services worker who is in, an outpatient environment. It does not matter who you are. Everybody wears an N95. Does that really make sense? Probably not, right? We, again, want to preserve the PPE that is most necessary for invasive procedures that produce aerosols for those types of providers. And so we might have a staged approach based on what our occupancy might be. And from a treatment perspective, there are lots and lots of good things going on here. Now, the interesting thing is that there's not a lot of definite data as far as RCTs and stuff like that, but we will continue to see more experimentation here. FDA just put out a press release about some of the antivirals. Particularly, we want to make sure that folks that are taking them under medical supervision. And so there's been a lot of imported drugs that have been caught by Customs and Border Protection that were coming from other countries where people were trying to stockpile stuff. And certainly some of these antiviral medications have, pretty significant cardiac issues that might be caused, especially with underlying issues that you might have. But one of the things that I think is really, really cool is this convalescent plasma technology, where we're essentially taking plasma from those that have been recovered and are no longer testing negative and infusing that in patients that desperately need this. And there's been some really interesting outcomes associated with that. And then lastly, we're seeing a lot of these patients with sort of that concurrent secondary bacterial infection. And so you will see the antiviral therapy simultaneously administered with this antibacterial therapy. And again, we'll understand a little bit more about that. And as we finish up and get to the Q&A perspective, I did want to again remind us of sort of the occupational exposure protocols. I got a lot of questions about this after the last program, and so a lot of people asked me to include this. But this is a chart that really looks specifically at either source control achieved, meaning that patient has on a mask, just a regular procedural mask, or no source control achieved. And so I've highlighted a few examples. So if we look at the first one, where the healthcare provider was not wearing any PPE, so we did not know this person was symptomatic, we contacted them. However, that patient was wearing a mask. So here you'll see that that's what we call a medium exposure, and we're going to exclude that person from work for 14 days. If we go to the next slide, though, where we actually have the person who was not wearing a mask, it changes. So if we look at the example of not wearing eye protection, that is going to qualify for exclude to work. However, let's say that the healthcare worker was wearing all of the PPE, right, except they did not have access to a respirator mask. That person does not require an exclusion from work because that's still a low-level exposure because the surgical mask is going to be somewhat protective. And certainly if we can throw a mask on that patient, we're going to be in an even better position. So I just wanted to clarify that as well. There's also a free course that's available out there, and you'll probably see more and more national providers do this, but this one's from the American Red Cross that's called Mental Health First Aid for COVID-19. And I took the course this weekend just to see what it was all about. It was very well done. It's completely free to anybody that wants to take it. And honestly, I think one of the sort of untold stories that's not yet been fully appreciated is the impact of this crisis on our resiliency. And while many of you may have answered that you have not directly cared for a COVID patient, I guarantee you've been affected by it. So you may not be physically putting hands on those patients, but your families, your loved ones, your community, your friends, your church, your gym, everybody's being affected by this as well. And so this is a great opportunity for us to reinvest in the piggy bank and say, how do we put something back in our own sort of bank account to make sure that we're ready to care for our patients and also be there as a support system for our providers. And then lastly, where do we go? Right? Well, as I've always said, every outbreak, every pandemic presents an opportunity. That opportunity is completely up for us to take or to miss. I think we need to take it and run with it. How do we prepare for the future? Well, let's think about our own procedures. Let's think about our own staffing models. Let's work with our administration, our C-suite, and our suppliers to make sure we have good PPE supplies and we have a plan to deploy them. I've seen some of the most interesting things like Tupperwares for masks. I've seen certainly brown paper bags. I've seen employees that have trash bags of their own PPE. You name it, I've seen it. And so what are really those best practices? How do we make sure that we have sort of a deployable and scalable kit, if you will, to ensure that we have continuity of care? If we know we're going to have a better demand for ICUs and we're going to have a bigger demand for vascular access and sort of that higher level care, then let's plan for that. If we can care for patients in other care settings, let's plan for that as well. And part of this really stops the mitigation risk that we have, right? We want to ensure that we can stop that community transmission, and that boils down to basic infection control, like washing our hands, making sure we don't contact our mucous membranes with PPE on, ensuring that we're actually going to keep the environment as clean and sanitary as possible. And lastly is looking at patient isolation. I absolutely hate the word isolation because it has such a negative psychological connotation to our patients, and quite frankly, I think it has it on us. You know, if you're a clinician and a unit and they say you've got 6 isolation patients, you probably want to pull your hair out before you ever meet the patient, simply because you recognize the burden, the workload that's going to put on you to go in and out of those rooms. And so there have been some amazing stories released. I just saw one actually this morning where an ICU nurse was actually playing tic-tac-toe through a window. And they did that every morning at the same time to keep that patient engaged and give them some sense of normalcy. And I really commend the people that are stepping outside of the box. But we've got to go further. And then lastly is, you know, again, let's hardwire those basic practices and reinvest in ourselves. One of the things that I'm terribly concerned about is we're reopening healthcare in many places, and yet we've not taken a day off. We've not taken a day off to debrief. We've not taken a day off to sort of resupply ourselves emotionally, physically, spiritually, whatever it may be. And I think that's something that's really important. So Blake, I'll ask you, I think we have one more poll question before we get to the resources. I'll ask you to put that up real quick.
We do. Let's launch that. Question is, how has COVID-19 impacted your life primarily? It could be financially, emotionally, work-life balance, all of the above. So it looks like a majority of the folks, all of the above, 57%. Emotionally, certainly, 21%. Work-life balance came in third for 18%, and financially is 4%.
Perfect. Thank you, Blake. And I think, Judy, to your point, you know, one thing that we've learned is that we are, as sort of a species, adapting how we work. So much virtual use is taking place that I'm not surprised at all that GoToWebinar is having a little bit of a hiccup. As we open it up for Q&A, again, I want to remind you to go to the CDC website. There are tremendous resources here. And I have many close friends that work at CDC, and I will 100% admit that there's been lots of failures coming from the agency with this particular one, but there's also been lots of successes. And I think we want to take the good and the bad and learn from it, and also help our public health colleagues. Yes, this guidance changes frequently, so please don't try to kill your infection preventionists when they come to you and say, hey, there's something new that's come down the pipe, we need to sort of switch gears. We're learning every single day more about this, and our goal has to be to protect ourselves and our patients. And so CDC is really the leader of that. There are some great resources that I provided here as well. As I mentioned, I'm going to also have Judy send out a link to a new video series that's available from CDC, particularly to help you around PPE related to the donning and doffing, so that we're familiar with that. And again, and I think Judy and Blake would agree with this, I can't thank you enough for the work that you do, either directly or indirectly, to care for these patients. We can't thank you enough for the work that you do to deliver life-saving vascular access with such a high degree of professionalism and specialization. As somebody who, is a traditional man and hates pain, my pain scale goes from 0 to 1, and anything above 1 I don't like. The ability to have a vascular access professional come to my bedside and competently insert a device and deliver that care is something that I find very refreshing, and I hope every profession has that opportunity. But COVID is really an opportunity for us to remind ourselves that these patients need us. We need these patients, and we need to care for them, and it's an immense opportunity to care for these folks. So with that, I'll put up my contact information, and I think we've got several questions. Judy, since I know some people might have to drop off, are there any specific closing comments that you need to make from the AVA side before I go through the Q&A?
Absolutely. Thank you again. And I mirror your admiration for everybody out there, and stay safe, folks.
How many of the elderly immunocompromised patients have survived?
The sad reality is not many. When we look at the data, especially New York has sort of been the melting pot of this. The majority of these are sort of the deaths have come from this environment. So it's really elderly people with significant comorbidities, and then other people with significant comorbidities is really where we've seen the majority of these. And some of the horror stories that we've seen with nursing homes with, bodies and things like that, having been in many nursing homes, taking care of these patients and trying to get them to a higher level of care, the practices are frightening. And I'm in no way saying that long-term care is not trying to do the wrong or doing the right thing. I do think they are. But they're just not equipped, they're not staffed, they're not resourced to do this in many cases, and they're not used to this level of acuity of patient. And so I think it's really an opportunity for us to figure out a better way to skin the cat. Can we create sort of COVID hospitals, which some places have done, where if you're, sort of convalescing from this, you can go there. But sending these patients right back to the long-term care facility where they have very limited resources, they have pretty let's just call it low-level infection prevention and control programs and minimal barrier precautions, that seems to be a recipe for disaster. So I think our elderly have unfortunately suffered from that.
Well, what we're going to do on a couple of these, especially if I've already texted you to ask you, I'm going to open up the mic, and we have our friend Michelle DeVries from Indiana had a couple of questions for us. So I'm going to open her mic. Shelley, you there?
I sure am. Hi, thanks. And fantastic job, Hudson, as always. One of the things that I was hoping you might address is we're hearing from some of our hospitals a proposal or a request that healthcare workers be tested every week so that the, patients feel confident. Obviously, that's not part of the actual recommendations that we've seen, but I'm hoping you may be able to address that if others are hearing that murmur among their staff as well.
I think that's a really good question, Shelley, and I think you would agree if we go back to what we do for other infectious diseases, and I'm just going to start with a real one that we all face, is that we have many healthcare providers that work with HIV or hepatitis every single day and do so very safely. We don't go around and test and do surveillance on those individuals. We make sure everybody adheres to standard precautions. We also don't test our staff for flu unless they're symptomatic, and we get that seasonally. So I think to your point, I would agree that there's really no rationale to go around and do that. And the other thing to think about, too, is from a diagnostic standpoint, is if you test negative today on Friday, that has no relevance to the fact that you might test positive tomorrow on Saturday. And if you're asymptomatic and you're a carrier and you're shedding, we've already had potential transmission. So I think really our sort of bucks and cents need to be spent on basic infection control practices. Employee screening is huge, checking for these folks that are febrile, symptomatic, et cetera. But I would agree with you that there's really no good reason to actually go around and screen. And from a liability perspective, given that my brother's an attorney that specializes in this stuff, I wouldn't want to go around and create data for which I had no plan to do anything with it. If let's just say all the antibody testing comes back positive for an entire ICU, well, do we close the ICU, which is what just happened at Emory University as an example, where we had one person that tested positive and now they've closed a particular ICU? Is that the right approach? If somebody's symptomatic and tests positive and there's a reasonable occupational exposure, then I think it certainly might make sense from an infection prevention standpoint to test those limited affected individuals. But again, when do we test them? And, if we look at our return to work criteria, it's 2 sequential negative tests, negative symptomology. And we want to do that on the outskirts of the incubation time period. Not, I see so many people, like you said, that'll say, well, I was just exposed yesterday, I need to be tested today. Not realizing that the chance of them sort of converting positive is very slim. So does that answer your question, Shelley?
Yeah, Hudson, thank you very much. And I think you hit the nail on the head. Thank you.
Another question here. Can you give a good source for what an aerosol producing procedure is? This seems to be very subjective.
I think that's an excellent question. And, if you are a healthcare worker trying to negotiate the necessity of an N95 mask, you can sort of self-justify anything. But when we think about aerosol generating procedures, there are specific ones that are called out in the CDC guidelines. Anything that's going to, sort of create those droplets in the air. So a nebulizer treatment is specifically called out. Intubation is specifically mentioned. A bronchoscopy is specifically mentioned. Other than that, there may be some other things that might be, and I would really defer you to your infection preventionists at your facility to determine based on what your sort of procedures that you're doing are. Some facilities do a lot of bronchs, and that would be a very high risk, and so those departments would absolutely need an N95 mask or some type of respiratory protection. But if you're just going into a room for a short period of time and there's no aerosols, we want to sort of treat that very differently than we would where there's going to be a reasonable risk. And so, if I think about job classifications, to Mark's question, respiratory therapists would absolutely get a N95 in my hospital because of the high risk and sort of the general classification of the work that they do. But if that doesn't answer the question, I can certainly give you additional information, but that is all available in the CDC guidance that's published online in the parentheses. Okay. Yeah, so if you're unable to get a proper fit with a traditional N95 disposable mask, my next recommendation, that's the cheapest option, would be to look at that half-face mask, where you have that respirator that's it's got the elastic around it, and it's long-term. It can be easily disinfected, and you just change the cartridges. For me, honestly, I actually prefer that over an N95. I get a better fit with that. It's more comfortable for me. It's easily disinfected, and I can pretty much wear it as long as the filter cartridges are good. If I'm a vascular access person, though, and I'm unable to get a good fit, and I'm going to be going, the entire day working with these types of patients, especially if you've been displaced from vascular access and you're helping out in the unit, I would certainly look at a PAPR. A PAPR is going to give you good protection. They're easy to maintain. They've got long battery lives. They're a lot more comfortable. And some of them don't actually require fit testing depending upon the one that you purchase. So you can work with your occupational health and safety folks to do that. I know of several anesthesiologists that are in this boat where they cannot physically get a fit test regardless of the type of N95. And so they've invested in PAPRs for those individuals. And so that would be a recommendation to consider as well.
Thanks, Hudson. I actually did find her question now. She failed fit tests this year and last. Her employer did nothing to help. This year asked what she needed to do and was told that she could pick up a PAPR in nursing services whenever she has a patient that requires it. The details are quite sketchy. What is the OSHA stand on this?
So if Leanne is going to be reasonably exposed to a respiratory pathogen that requires the use of a respirator, then the facility is legally responsible under the OSHA's law and regulations to provide her that respiratory protection. So it is certainly reasonable, though, for the employer to allow her to come check that out if there were to be a need. To provide every single employee a PAPR 24 hours a day is not really financially feasible. And it's unlikely that all of the people that need PAPRs might be on duty at the same time. Now, if for whatever reason they were, then the facility would need to look at that. But a lot of folks that I know that have failed fit testing with an N95 are able to get a good fit testing with a high-quality half-face respirator. So that would be sort of my next thing, and that's a lot cheaper. Those are between $40 and $60, whereas a PAPR can be upwards of $1,000. And then a PAPR is certainly designed for people that are going to be really exposed, need to be more comfortable as well. But as long as the employer is providing it, then that is acceptable. The other thing is that some PAPRs do still require a fit test, while others do not. And so it's important to make sure that the model that she would be issued does not require fit testing. If it does, then employee health would need to provide that service for her prior to using it.
Great info.
I'm going to ask a multi-stage question, and it's all surrounded by PPE. So when do you wear eye protective covering?
So I would recommend you wear it all the time. Eye protection is something that I've sort of built into my practice after Ebola period. So if I'm interacting with the patient, I wear at least safety glasses. Certainly now you would add a mask to that. But eye protection in general is part of our standard precautions if there's any reasonable exposure to our mucosal membranes. So I'm a big pusher of that. I think it's something that we should do. If I'm going inside a COVID ward, I'm absolutely wearing eye protection. I'm wearing my mask. I use a bouffant cap. And then if I have access to it, I certainly wear coveralls. That's just my own personal preference, but eye protection I think is very important in this equation.
Along the lines of eye protection, How about for contact wearers? Should they be switching to their regular glasses, or could they continue to wear their contact lenses? What are your
So
thoughts on that?
yeah, I think that's a very important, reasonable question. So there are different ways to skin that cat. So you could certainly wear the goggles, which would allow you to wear the contacts underneath, or you could look at a face shield. I've heard, and I don't wear contacts, so I can't speak from experience, but I've heard that people that wear the goggles the entire shift have a lot of eye dryness if they wear the goggles, whereas they don't experience that same phenomenon if they're wearing the face shield. Because remember, these droplets are going down; they're not coming up. So we're really worried about good respiratory protection and having something that's going to cover our eyes, mouth, and nose. So a face shield would probably be the most comfortable for that, but eye goggles would be completely fine as well. And then you could, of course, wear safety glasses. But there's really no requirement for you to remove your contact lenses as long as your eyes are covered.
Thank you,
Very
Hudson.
good. So Margaret is asking, what's your opinion on that healthcare providers are provided a new surgical mask only every 3 days, has to reuse this mask 3 days in a row?
Well, I'll give you my personal answer, and I'll give you my official hat answer. So, my personal answer is I think we've got a big problem. The reasonable answer as far as healthcare settings is that if that mask can be effectively reprocessed, then okay, only in the case of a pandemic. But I believe the question was around surgical masks, and surgical masks are good at best for maybe an hour. So they don't really provide a lot of protection when we're running around. We've got sweat going through them. They get, contact with moisture, those types of things. So there's a lot more. I'm not actually seeing facilities reprocess surgical masks. I'm seeing them reprocess N95s. And what a lot of places are doing is that they're wearing some type of cloth reusable cover over the N95 respirator that the employee maintains on their own, or the facility might be issuing them. I know one facility that I've worked with recently, a church group made about 5,000 cloth masks. They take them off at the end of each shift. The hospital launders them in-house, and then they're put back in their PPE bags before they come back on their next shift. So I would not recommend reprocessing surgical masks. I think that's a very dangerous practice. N95s are bad enough, and some of the UV studies and other studies that have been published out there, they don't last long even when we reprocess them. So the goal, and sort of gold standard of this activity should be to have a piece of PPE that's 100% functional and effective and safe for you as a healthcare provider all the time. And that may be, everybody having some type of half-face respirator. That could be having more access to PAPRs, but, reprocessing these things that are intended for disposable use and are regulated by FDA for disposable use is truly a sign of how bad things are. And so I'm not a fan of compromising safety for any circumstance at all. And I would really caution people. I've had several people email me after the last webinar with personal stories of being asked to perform procedures without any PPE. And under no circumstances would I ever recommend a healthcare worker put yourself and your life at risk. Even as bad as our patients need us, because your expertise goes so exponentially far. It is so invaluable right now that we must do everything we can to protect ourselves. And so I would also encourage us to, yes, make good decisions based on what evidence we have today and what resources we have, but never, ever compromise your personal safety, because it can't be taken back. We don't have a way of undoing the past. So N95s, I think, are somewhat safe, but I would never recommend that for a surgical mask.
Agreed. We have a follow-up, actually from Leanne. Are there half face masks criteria that we should be looking at when shopping? Do some of these not work?
So there are, the biggest criteria here is, are they NIOSH tested and approved? So if it has that on the product labeling, then you're okay. Obviously I can't recommend any specific brands in the content for today. If you are struggling with finding the best ones out there as far as sort of efficacy profile and comfort and things like that, I'm more than happy to have you email me, and I'll address those as one-offs. But there are several national brands out there that you can probably all figure out that do provide good, high-quality product that will allow you to reuse that. And the reason I'm a big proponent of looking at these half-face respirators is that those are so easy to maintain and they're yours. So you will always, always have your own respiratory protection. And depending upon the filter cartridges you get, some of those, I've got one set that lasts up to a month. Well, if I have, 6 filter sets, I have 6 months of my own controlled respiratory protection in my possession. And so I think we need to sort of switch the dynamic and say we're not going to be dependent upon China or disposable PPE being reprocessed. We're going to be completely dependent upon our own sort of internal supply chain and protection mechanisms, and that's a quick way to do that. So, Leanne, if you've got specific questions or anyone else, I'll be happy to shoot over some of the recommendations of ones that I've personally used and have found acceptable.
Thank you, Hudson. What's your take on air cleaners and filters when it comes to coronavirus, COVID?
A good, simple HEPA filter that's healthcare grade is completely acceptable. I don't think we need to go crazy. I've heard a lot of people that are closing rooms for 6 hours and doing UV and all this other stuff, and it's really not indicated. When these droplets fall to the ground, when they fall to the environmental surfaces, they are extremely easy to kill. This virus is inactivated with traditional soap and water on the hands, so it doesn't take a lot of antimicrobial activity with these disinfectants to inactivate this stuff. It's super easy to get rid of. That being said, you do want to make sure that you have adequate air exchanges. And so if I'm going to, let's say, determine where am I going to put what patient, and I have limited airborne isolation rooms, well, I'm not going to put every single COVID patient in an airborne isolation room unless I have enough, which is traditionally not what's happening. So you're going to start to see cohorting more and more with these types of diseases where we close floors and we've got an entire floor or an entire hospital that's just COVID related to that. So I think that's going to be sort of the new wave of the future more than anything else that we'll see.
Here's a great question, actually. This person's employer says they cannot bring their own PPE in and have to re-wear what they are provided. What, in your opinion, is the legality of the issue, and can they really determine what we wear if they don't provide us proper PPE?
Yeah, that's a tough question. As a healthcare provider, I want to use what's absolutely best, and it's different outside of hospitals. So if you think about some of the other practice environments, people are bringing their own stuff in all day long, and there's no restriction about it at all. In the hospital environment is where I've seen this traditionally. So number one, you are required by law to be issued respiratory protection if that's part of your job requirements. So that's an OSHA regulation, period. Number two is that equipment must be functional and it must actually meet the requirements to protect you. So for example, if you have documentation or the manufacturer has documentation or CDC says hypothetically, I just want to stress hypothetically, this N95 respirator can only be disinfected using vaporized hydrogen peroxide for 3 uses, and your employer gives it to you for 4, 5, and 6 uses, they are now in violation of evidence-based recommendations, and there's liability for the employer. So it really depends on what the piece of equipment is, what the current testing parameters are, if any. But if an employer is not providing you PPE, then you're in a different position because they have to. And I know hospitals are in a very bad position. I'm very respectful of that, and there's some fault there with the hospital, and there's a lot of fault with other things, which we won't talk about today. But you must be offered that, and so I would come to an agreement with the employer to say, if you're unable to provide me PPE, right? It doesn't have to be perfect, but it needs to be acceptable and safe. Then I'm requesting a deviation, and I'm willing to have you fit test me with my PPE that I'm going to bring in. And I'll tell you, I've seen this a lot with contracted physicians and independent practitioners like nurse practitioners that are contracted by hospitals that are in the hospital wearing their own PAPR. And they just said, this is how it's going to be. If you want us here, this is what we're going to do. And that's how they've done it. So I think every facility might be slightly different, but under no circumstances can a facility, request or require you to function without PPE.
What's your feeling about wearing a capper while placing PICC lines? And the concern here from the attendee, Debbie Morgan, all the way from Florida, she's saying she's concerned about that airflow contaminating the sterile field.
Yeah, so I mean, I think that's a very real question. There are different types of PAPR delivery systems. Some of them will not contaminate the sterile field. If you are interested in going and getting PAPRs for your team, which again, I think is a very good idea, just FYI, I would look at the models. There are several companies that offer models that can be used in the perioperative procedural environment and are being used right now that sort of specialize in that have a different type of airflow that will not disperse that onto the sterile field. So if you need specific help finding what those are, you're welcome to email me. But there are specific models that will be able to meet that. They're a little bit more pricey, but again, if you're doing procedures, your risk is higher in order to do that, and you want to make sure you can accommodate for that patient safety aspect if possible. But there are alternatives that will do that.
And Hudson, what's another kind of follow up to that was what's the major difference between a capper and a papper?
Well, you know, even the word PAPR, there are different sort of interpretations. So you're looking at positive and continuous. So think about it as the difference between a CPAP and a BiPAP. When I have this conversation with people, I ask a lot of questions. What are you going to be using it for? What's the length of time you'll be using it for? Are you going to be using it in a procedural area? And there is actually, I believe, a checklist on the NIOSH website. I'll try to dig it up. That actually has the questions that you should consider. And if I can find it readily, I'll send it to Judy and have her send it out to everybody that's attending. But that would be where you would want to start is what's its intended use? Who will use it? Is it going to be personal use or shared use? And then do you need something that's fully encapsulated? So for example, I think her question was about, you know, inserting lines and things like that. I would personally look at sort of a self-contained helmet, for example, that's not going to have any airflow towards the front at all. Versus some people that are just walking through a unit. That may be perfectly acceptable, but we want to make sure that for its intended use, you're going to have the appropriate thing. Sometimes that may be a PAPR, sometimes it's not. Sometimes we may want that continuous flow, other times we may not. And I think we want to make sure we have the right type of device for every single procedural area and have those dedicated. I think that's the big risk here is that if we go out and buy a whole bunch of PAPRs or even the face mask, we need to ensure that we have something dedicated for departments so that we have enough per shift. So if you are a vascular access team and you're out there and you're going to have, in a pandemic situation, 3 people per shift, then you need to have 3 PAPRs. Or you need to have 3 face masks or whatever it may be, face respirators. So I think that's something that we've got to strongly consider.
We have a question from Dawn. She wants to know your thoughts on training a new vascular access nurse at the bedside during this time. Now, I have my opinion. I'd love to hear yours.
No.
I'm with you.
Yeah,
I'm with you. Why expose?
This is not a time to do any type of new hire training. You know, new hire training can be go do COVID testing or something like that, but I don't think we want to introduce an unknown variable into your procedural area. And we've already seen this with our physician colleagues that are in their fellowship, residencies, et cetera. You know, the recommendation from the fellowship programs and residency programs is that student trainee should not be in the room unless there is a medical need, clinical need for them to be a part of that procedure. That does not include their ability to check a box to say they've done a procedure. The same is true for our vascular access clinicians. So while it may be, you know, horrible timing to delay hiring somebody or onboarding them, I would absolutely not expose somebody in this type of situation where we've got a lot of variables sort of at play. We've got limited PPE. I know a lot of healthcare facilities are also doing furloughs, so it's really probably just not the best time to do that and do it safely.
I agree. I think that trainee could be doing some other things that are more productive for their training, i.e. Assessing the lines that are on the floor that are possibly not COVID patients. There's many things they could be doing for their training as opposed to be going into that room. And also these patients are superbly sick and they don't need multiple pokes, which often happens with trainees. So I agree with you wholeheartedly. Let's change directions ever so slightly is talking about rumors that bodies must be cremated that are COVID positive. Have you heard this?
I have heard that amongst many, many other things, sadly. Believe it or not, there is postmortem guidance available on the CDC's website that is out there. So if you are looking specifically for that information, it is available on the CDC website. There's really not a ton of stuff that's very different than how we would sort of handle or transport any other body. Unfortunately, there's a lot of bad information out there, but there is specific guidance out there to address that. That was a rumor CDC has heard as well. There's also rumors about, you have to transport the body in triple bags and stuff like that, and that's not true either. So there are a lot of misinformations out there about that, unfortunately. So that's why there is postmortem guidance. I will also tell you that as of yesterday, CDC has updated the webpage, which I'm going to go back to here for just a second so everybody can see it. And this webpage has now got practice information that's divided by clinical practice settings. So if you're in an outpatient setting, or let's say, I know we've got several colleagues that are pharmacists, there's pharmacy information, there's hospital information, there's long-term care, there's home health. So regardless of where you're coming from, representing, the various facets of AVA membership, there is now sort of a segment for you on the CDC website, and that was direct feedback that was given to CDC to create that.
I know we've seen this a lot, people wearing regular masks or surgical masks over N95s. Does that make the N95 safer for multiple day use?
No, it doesn't. That's not even a CDC recommendation. That's something that a lot of people are doing to it's something that I think is common sense to sort of protect that. But again, a surgical mask doesn't last very long. So you're better off handling your PPE appropriately. Now, if that N95, for example, becomes wet, then that needs to be immediately discarded. If it tears or anything like that, then that needs to be immediately discarded. So it's really about integrity of the device. I'm not honestly very concerned about my N95, with covering it or anything like that. Now, again, anytime I'm interacting with patients, I'm wearing a face shield. So I have a little bit different perspective, but there is no current CDC recommendation to wear any type of covering over the respirator mask. If you want to do so, that's fine, but remember, more PPE is not better. And when you have more PPE, you have higher risk of exposure for contaminating yourself when you're doffing it.
We have Susan asking, she is a high-risk patient or high-risk provider, high risk with asthma and over 60. Should she refuse to place a line in a positive COVID patient or a rule-out patient?
So I think it's very reasonable to request not to do that. If you've got a significant comorbidity, that would be a conversation I would have with your occupational health department, along with the infection preventionist in your facility to say, I have uncontrolled asthma or something like that, or I have COPD, that puts me at higher risk. You are in that vulnerable risk index. And, it would be advised to have somebody else do that if you had that capability. The other option, too, is that there's a recommendation out there for those that are healthcare providers that have recovered from corona, that have some evidence of immunity, to utilize them as well, because they should theoretically be more immune to reinfection of the virus. But I don't know how successful that strategy will be as far as sort of opting out, if you will, when you're a specialized person and you may be the only specialized person available. So, I think if you're wearing proper PPE, and I've cared for a lot of these patients myself, and I'm meticulous about my PPE, then you should be okay. I mean, I also have asthma. It's not uncontrolled, but it is certainly a risk factor that I'm aware of. But if possible, I think it is reasonable to request an accommodation with that if that's something that's of great concern to you. We've got to be careful about that, though, because we can't create precedents where you just opt out of everything. So I think it's a slippery slope associated with that. And if you've got good PPE, you really should have no risk of exposure. We have not yet, to my knowledge, and CDC confirmed this in talking to them earlier this week, that we have not seen transmission to healthcare workers where healthcare workers were properly, and I want to emphasize properly, wearing the PPE and taking it off properly. What we've seen is transmission where those two things were not done correctly. So hopefully that will be reassuring to those with comorbidities on the phone. Absolutely.
Along with the PPE, what are your thoughts on shoe covering?
They're pretty worthless, to be honest with you. So I'm not a huge proponent of them. I have size 12 feet. I rarely find shoe covers that fit me well, especially if I'm wearing any type of boot. that would be the absolute last thing that I would be aware of if I was thinking about risk. That being said, we also want to exercise good common sense, and I think good common sense includes not wearing our shoes outside of the healthcare facility. So, if I'm in a hospital setting or a critical care transport setting, which I do a lot, I change clothes at the facility. I remove any of my shoes. They go into a trash bag. They get disinfected. So I actually have a thing in my garage that looks like a little kitty litter sort of tray. I have liquid disinfectant in there. I stick them in there for the contact time. I remove them, and then they stay in my garage. They never, ever enter the house. They never enter my car. So I would spend more time doing basic infection control measures like that. And a lot of hospitals are also providing facility laundered scrubs, which I think is fantastic. So you're not taking this stuff home on your fabrics, and you can have a reasonable assurance that when you go home to your families or your loved ones, you're not bringing this stuff home.
Agreed. What about placing PICCs with or without full face protection?
I'm not sure are we referring to a mask or are we talking about a face shield?
I think they're talking about face shield, but because a mask is required, some sort of eye covering. So I believe they're talking mask or a shield. Sorry.
Yeah, I mean, a shield is perfectly fine. There's lots of bedside procedures that are done, especially by physicians wearing shields right now. I don't see any issue with that at all. I'm a huge personal proponent of the face shield because it's so much more comfortable. For me, wearing goggles, I get claustrophobic in about 20 minutes, and I get very hot. So a face shield is a good, reasonable alternative for me. It provides me excellent protection. Some people ask me often about, should I wear eye protection underneath the face shield? And the answer is no, you don't have to. If you want to, go for it, that's fine, but there's no recommendation that you need to do that. The face shield is a form of eye protection if it's properly fitted and it's being worn correctly.
How accurate are COVID-19 tests? Question mark. I've seen, it sounds like I'm trying to text to speech here, but I've seen where some symptomatic patients test negative on the first and even sometimes the second time or 3 or more times. But the pulmonologist intensivist feels like the patient's probably truly positive. What's your thoughts on that? And I know of a couple patients this has happened to. 2 negative tests, they talk like a duck, they walk like a duck, and it turns out they were positive.
Again, I'm going to go back to a test is one piece of potential confirmatory diagnostics. So if I am, and I'm going to use an old adage of, if you've ever taken ACLS, you know what I'm talking about. If your instructor throws up asystole on the monitor, the absolute first thing you do is you check for the presence of a pulse and check your leads. The same is true here. If I have a symptomatic patient in a community with widespread transmission and they are presenting clinically to me that they have COVID, I don't care if the test is negative or not. I'm going to treat them and isolate them as such until proven otherwise. Now, could it be something else? Absolutely. But I'm going to take the same respiratory precautions, isolation precautions, whatever you want to call them, because that test could very well be positive tomorrow. So a testing, principle is only one aspect of the equation. There are also, without going into a lot of diagnostic details, there are a lot of variables with the different tests that are available. And as more tests get FDA approval, it's important to know the sensitivity of those tests. And that's where your medical laboratory experts can come into the picture to help sort of identify that. But there certainly can be false positives. There can be bad collection techniques. When we get to more of these nasal swabs versus the nasal pharyngeal, that's going to help because it eliminates some of the risk to the provider and also makes it a little easier to collect. But, if you contaminate a specimen or you don't activate the reagents correctly, stuff like that, there is potential for error, just like any laboratory test. So I would say treat clinically, use the test as a confirmatory or a source of exclusion, but you want to closely monitor. And that's one of the reasons we say return to work criteria for test-based strategy is 2, negative tests, not just 1, but 2, to make sure that we have good sensitivity with that test and good confidence.
So did you just say to come back to work, they'd have to have 2 negatives?
If you're using the test-based strategy. So
Okay.
There's different strategies that you can use. So if you're going to use testing as a return-to-work mechanism, CDC's criteria is 2 back-to-back tests at least 24 hours apart that are negative. You can also do it with symptom exclusions. There's another strategy that you can use as well, but that's for testing.
Very good. What do you think about reusing? We're going back a little bit to the reusing after sterilized, or about masking or masks issues. What do you think about reusing N95s after they're sterilized?
Well, first of all, they're probably not sterilized, depending upon what you're using. They're probably reprocessed. Some of them may be sterile. So, first of all, understand which one you have access to. So if you are getting one that is coming back sterilized, anytime we're doing a sterilization cycle, regardless of the modality, we're degrading that mask. And so the question is, how many times can I redo that before I have some type of degradation? So, for example, if the current guidance out there for whatever brand is you can reprocess it 5 times, then you should not reprocess a 6th time. The other thing that might happen, and this happens frequently, is that the straps, fall apart or something like that. So it's important to do a seal test. There's a difference between a fit test and a seal test. And that seal test is really done by the user when they first place the mask on to determine when they inhale and exhale, are they still maintaining a proper fit? So if there's degradation of the mask that's observed at that time, then you know that you need to toss that. And I've always personally recommended doing that seal test in front of a mirror so that you can see how that mask is functioning. But that would be probably my best recommendation. And there is a table that's now available on the CDC's website that does list the different modalities that have been, I don't want to use the word approved, but recommended, that have some type of validation data. And it'll tell you what your hospital can safely do and what they can't.
Thank you. Well, when you walk into a positive patient's room with COVID-19, do you recommend a bonnet, a hat?
It's not currently something that's required, but it's not a bad idea. I would never, ever tell somebody not to do that. And I think anything that we can do to try to keep our bodies as clean and sanitary as possible is a good thing. So I don't really have an objection to that at all. It's not going to necessarily cut down on transmission to others, but I think it's something that certainly is a comfort measure for us to make sure, we feel like we're covering our bodies. But this isn't Ebola, so we don't really need to, go to too big extremes, but I don't have any qualms about that at all.
Reality, we're probably going to be wearing one at some point if we're seeing the patient for vascular access. So not a bad idea. So we have a question about construction grade N95s. Are those appropriate?
They are appropriate as long as they're on the FDA's list of approved devices. So the benefit with FDA is that they regulate those masks regardless of where they're used. So even the ones that are sold at Lowe's and Home Depot and places like that, and Ace Hardwares and stuff, those are also still regulated. So FDA has published specific model numbers on their homepage, which is fda.gov. You can click on the document that talks about the mask, and they update this frequently. It's updated at least in the last week. And it does list by brand, by model number, and by who makes it, the manufacturer, which ones can be used in a healthcare setting right now. The unknown of that variable is what happens when this is all over. Is FDA still going to allow for those to be used in sort of general practice? I would say if I was FDA, I would sort of pull that back and say this is only for pandemic purposes. So for purposes of planning and thinking about future preparedness, these are fine. But we want you to use the ones that were specifically approved for healthcare as your primary source of PPE. That would be what I would think FDA would do, but they haven't yet published any guidance on that because we're still in sort of the thick of things, if you will.
When it comes to pregnant nurses, are there any special recommendations for how to protect them?
There are. So just as there is a specific guidance for postmortem, there is now guidance for pregnancy. So if you go to the same website that's listed on my next to last slide, on the left side of the screen, you're going to see an option for clinical care and infection control. And you can hit the plus arrow and you will actually see the recommendations for patients that are pregnant, that are also working in a healthcare setting. They're very, very reasonable in nature. And again, there's also new guidance for things like dialysis, folks like that as well. So I would say 90% of your questions, regardless of your sort of personal situation, are now addressed. And that's something that's changed in the last 2 to 3 weeks. So when we first did this webinar with Judy and Blake, it was very sort of up in the air, but there is now concrete guidance for many of these specific questions that's available for free. So there are 2 new posters. I'll make sure, Judy, don't let me forget. I'll make sure to send those so that you've got that. But when you think about putting this on, you're going to always start with hand hygiene, right? And then you're going to move to your gown, followed by your respirator or your face mask, whichever one you have. Then you're going to put on your eye protection. And then lastly, you're going to put on your gloves. When we sort of go out of the room, though, we're going to start with a sort of a flipped approach, which is looking at the things that are most contaminated, which is always going to be our gloves. So, you know, and there are people that will also do hand hygiene of the gloves. That is not currently recommended for this particular pathogen. We did that with Ebola. Then you're going to go to the gown. You can perform hand hygiene again. So again, you're trying to minimize transmission. Then you're going to take off your eye protection, followed by your respirator, and then hand hygiene again. So, you know, when you come out of the room, start again from the dirtiest piece and work towards the cleanest piece, and then immediately practice hand hygiene after that. But they did release a document, I believe it's for both face mask and respirator, that's pictorial. So I'll make sure that Judy gets a copy of that and she can share that. And I would encourage you to post that. So if you've got like a vascular access cart, post it on the cart, post it in your break room, make sure it's available in your ICU units, places like that. It is an invaluable tool. And again, if you don't do this all the time, it's different, right? Because if you think about going from like an MRSA contact precautions to this, we're talking about an upgrade here. And we're really looking at those enhanced respiratory protections. So I would use that as a tool, but I'll be happy to share that.
What is your opinion on keeping safe entering and exiting multiple long-term care facilities, rehab centers, et cetera, within the same day? And these facilities also have limited PPE to provide to the nurse.
Yeah, I think that's a difficult one. I mean, if you can, I would try to get some type of dedicated environment where the patient could be brought to you. You know, that's a big thing in long-term care, is having some type of environment where you can have somewhat control over the cleanliness. You know, if you're going into a resident's room and there's 2 residents in the room, especially if you're going into a COVID ward, you've been exposed to COVID whether you think it or not. So I think start there. If the facility is responsible for providing you PPE versus you being able to bring your own PPE, I would be very cautious if I were you, because I think you're going to find a large disparity and a large variety of different types of PPE available in the long-term care setting. And so again, my advice has always been control your own destiny, control your own safety, and if the scene is not safe, you don't go in. So, you know, I would certainly have a conversation with the nurse that you're going to be interacting with to say, I need to know if you have the following things. If you don't, we're not going to be able to perform this procedure, because, you know, you've got to take care of yourself first. And so my recommendation would be to control your own destiny, have your own PPE that's issued by your contract company, just like you might bring in your own kits. But I wouldn't personally recommend on long-term care to provide that stuff for you. That's just my own gut reaction.
Thank you. I think I'm going to bring Shelley DeVries back on. She has another question for us.
I'm shocked.
Isn't it? I'm shocked too. Did I unmute you? Cannot take control.
Hi.
There
Sorry.
you are. Hi.
So are you talking about the, I've sent a lot of things, Judy. I want to make sure I'm asking.
Whatever you like. Whatever you like, dear.
So the only thing I think I was going back to, Hudson, was there was a question about the masks over N95s. And just to clarify, from my reading, when many of us have had to gone to CDC's contingency or crisis recommendations regarding N95s, they do offer, while the face shield is preferred, not everybody has access to a full-length face shield. So they do indicate a mask over the respirator could reduce contamination of the N95. So I totally agree with you. A face shield is preferable for many reasons, but they do give us that option if we're in that crisis strategy of some reuse of the N95.
Yeah, I think the challenge is that face mask has limited longevity of about 30 to 40 minutes. So, you know, then we've got contamination that we're now removing on top of the N95 as well. So, you know, best case scenario would be to try to cover the entire orifice, if you will. But
Not just
an option.
We've got
Hudson.
Pam. Oh, go ahead. Your turn, Blake.
I was going to say, we've got a couple questions, and I know we've kind of talked about the disinfection of face masks and things like that. Is there any evidence out there that suggests that hydrogen peroxide, UV light, any of those sorts of alternative disinfecting methods have borne any fruit in disinfecting face masks?
Yeah, so there's actually a pretty extensive guidance document that looks at everything from vaporized hydrogen peroxide to steam to heat that actually talks about the different modalities and their effectiveness on reprocessing N95. So, what most hospitals have is some form of steam or heat sterilization. That's what most hospitals have ready access to. They may have a vaporized hydrogen peroxide. There may be aeration times dependent upon the manufacturer. So, I would recommend using that document and talking to your central sterile processing folks to determine what do you have access to, what's scalable for you to have access to. There's also some services that are now where they come and actually pick up the PPE, they zap it overnight, and they return it to the hospital. So depending upon sort of what your estimated volumes are, there may be some vendor relationships that you have to establish in order to maintain the sort of scalability of your operation. So I would really look at all of those different things. But many of those technologies that are mentioned are highly, highly effective. And again, the virus is not hard to kill. So, most of this stuff, if it's used correctly, it's going to be extremely effective.
We have a COVID floor at our facility, and lab personnel are not going to that floor. So all patients are nurse straws. How much should we advocate for more invasive lines in these patients to avoid repeated exposure to vascular access and other staff for repeated IVs or lab draws?
I'm trying to think of exactly what this person is trying to get at with the question. So I'm not sure if the question is regarding around needle stick exposure or if it's just going into the room exposure. So I'll sort of address both.
Well, tell you what, let me get her on the line.
So if you're talking about general exposure, again, anything we can do to minimize exposure and sort of our depletion of our PPE is good. That being said, we also want to be able to provide that humanistic aspect of care that's so clinically important to patient recovery. So we want to sort of, and that's, I know on the last webinar, some people asked me about, do you recommend putting IV poles outside the rooms and not going in the rooms? I get it from a logistical standpoint, but I also, feel terrible for these patients that are completely removed from interactions with other people. And so we want to make sure we maintain a balance of doing what's safe for us and doing what's needed for our patients. So, certainly if you can establish a peripheral IV and you can draw your labs from that, great, fine, dandy, but I'm not really sure how that's any different than going in and doing peripheral sticks if needed. I mean, if the frequency of the draws is going to be substantial, then absolutely establish a vascular access device that's going to be more comfortable for the patient. But if we're talking about a draw here and a draw there, it may not be medically necessary or needed. If the other part of the question that I know some people have asked is, do I need to be concerned with a needle stick with this? And this is not a bloodborne pathogen. So yes, you absolutely should be concerned in general about a needle stick with anything, but that's not the route of transmission with this particular virus. So, we're really looking at this as a respiratory droplet type thing. So you're going to treat that just like any other potentially infectious specimen and make sure you're maintaining good, needleless devices, ensuring you're disposing of stuff in sharps, et cetera, just like we would normally do.
Okay, Blake, do we have one, or would you like me to pop? Oh, it's my turn. Never mind. So, do you recommend the best way to protect our ultrasound machines in a COVID-positive patient's room? I do have an idea for you, Deborah, but go ahead, Hudson.
I mean, again, you can disinfect stuff pretty easily. So, am I going to tell you to go spend $40 or $50 on a cover? No. If you're able to, disinfect all the surfaces of your ultrasound machine, then disinfect all the surfaces of your ultrasound machine. I think we get a little bit overly reliant in healthcare on covers, and covers are only as good as they're applied, and they're only as good as their the sort of integrity of the cover itself. So if the cover tears and you never see it, I've seen a lot of people that use covers and then they don't disinfect at all after they remove it. And we unfortunately learned this the hard way with things like vaginal ultrasounds and stuff like that, where probe covers were breaking. The clinician didn't realize it. There was no disinfection taking place, and there was transmission of HPV and other things. So, we want to sort of use a common sense approach to this. If you use a probe cover, it still requires disinfection after the fact. You know, I don't really think there's much that has to change here. Again, the virus is very, very easily inactivated with our regular hospital-grade disinfectants, which you have access to. If your hospital is out of disinfectants, and this is a question I get a lot, you can absolutely go buy liquid bleach and make your own 1 to 10 dilution of bleach, which is going to be just as effective as anything commercially prepared that you have. And bleach is highly effective against the virus as well.
You're just like our own Martha Stewart, aren't you? Mix it with 1 to 10. 1 to 10. I love giving you a hard time too. I think we're gonna ask one more question of you, Hudson, and then anything else. I know we're gonna have follow-up webinars on this topic as we keep going, but let's end it with, we've talked a lot about those immunocompromised patients, us, the folks that are older, more comorbidities, but we've also heard about young people without comorbidities getting sick and dying. Do you know the statistics on that?
I don't. I would be hesitant to provide something like that without really digging into the data, and the data, you know, is changing on a daily basis. I unfortunately had a friend that was victim to this, that, as far as I'm aware, did not have any significant comorbidities. But so it's a non-discriminating virus in some aspects. But we certainly recognize that there's a lot of vulnerable populations out there. So, you know, do I know the numbers? No. Is it a risk? Yes. But we know that the majority of people that are negatively impacted by this are those with significant comorbidities. And I think the New York City study is the best example of, you know, unfortunately looking at the long-term care environment and then those that had significant comorbidities. If you think about sort of the epicenter of the U.S., and 90% of their patients that are hospitalized have significant chronic comorbidities. That's a big percentage that I think we need to focus on. So we'll probably learn more and more about those that did not have health issues. And I think we'll honestly learn a lot more about our pediatric environments as testing becomes more widespread. And we look at sort of antibody protection. You know, is antibody protection, does that mean lifelong immunity? How long is the immunity? We're not yet there. We've got a lot of ways to go with that.
Very good. Well, Hudson, we can't thank you enough for your expertise and taking all this time to answer the questions and give a great presentation. I appreciate it. And everybody on the line still, thank you so much for hanging in. We love that you've hung in for the 2 hours, and we hope to see you at our next webinar.